So, good evening. I'd like to extend a warm welcome to all of you, our valued alumni and esteemed colleagues, to this month's academic meeting. It's a pleasure to come together as a community of SNites to share knowledge, discuss the latest advancements, discuss our difficulties in our respective fields, and to learn from one another. This meeting offers a unique opportunity to bridge the experience and expertise of our alumni with the fresh insights of our current practitioners at Shahinur. Your continued involvement and contributions like this help to shape the future of SNites academics, especially POWWOW. And we're really excited to engage with you today in meaningful discussion and exchange of ideas. Thank you all of you who've joined us today, and we're looking forward to a productive and enriching session. And with that, I invite Dr. Mona Khurana to invite the today's speaker and the panel.
Thank you, ma'am, for the wonderful introduction. So I'm very thankful to Dr. Shahinur, who decided to share her challenging and insightful cases with us so that we can also learn together about the management of these difficult situations. So let me introduce Dr. Shahinur first. So she is a consultant at Shankar Dev Netralaya, Guwahati. She did her MBBS from RGUHS, Karnataka, and MS from RIO, Guwahati. And of course, she did her fellowship in glaucoma in Shankar Netralaya from 2007 to 9. She has several publications in national and international journals, authored chapters, and presented at the WGC as well as the UKPGS conference. So I welcome her and thank her and looking forward to her presentation. So at the same time, I'll introduce Dr. Shweta also. And as the other panelists come, we will start joining because they're on their way from the meeting. We'll introduce them.
I think it's perfect. We can start, and as and when they join, we'll keep a watch and we can introduce them. You can introduce Dr. Shweta.
So Dr. Shweta is a very senior consultant in Indira Gandhi Eye Hospital and Research Center, Lucknow, and also, as she mentioned, in charge of the academics there. She did her MBBS from BRD Medical College, Gorakhpur, DNB from Pondicherry Institute of Medical Sciences, and a fellowship at Shankar Netralaya in glaucoma. And she's a very active person with organizing secretary for GSI at Lucknow and many wet labs also to her credit. And she's a regular presenter at international, national, and state conferences. And we are looking forward to her comments and experience. So I think we should hand over now to Dr. Shahinur to start her presentation.
Good evening. Thank you, Mona, for the introduction. And shall I start sharing my screen?
Yes, and my co-moderator, meanwhile, Dr. Suganeswari, I don't think she needs any introduction. So she'll be helping us. She's always there with the retina backup. So we look forward to her comments in these two cases, which are, of course, have a major part of the PR surgery to be discussed.
Thank you, Mona. Good to be here with you. We share the OTs also, we share patients, so we share the same platform today here.
Thank you for this opportunity. I'll be sharing two cases which I had managed, and these were difficult cases, and I thought it would be worth sharing my experiences so that I can learn more about management of these cases from experts. So my first case was that of a 13-year-old boy. He had come with a complaint of gradual decrease in vision in both the eyes since last 1 month. He gave the history of being diagnosed to have glaucoma elsewhere, And he had baseline intraocular pressures of 52 and 48 in the right and left eye respectively. He gave no history of steroid usage, and there was also a history that his great-grandmother had a blinding disease which was unspecified. The medications that he was taking the travoprost and dorzolamide timolol fixed dose combination in both eyes. So on examination, the right eye visual acuity was counting fingers at 3 meters and the left eye counting fingers at 1 meter. So there was no improvement in his vision with pinhole, and the pupillary reaction was sluggish in both the eyes. The lenses were clear. IOP was 30 and 34 in the right and left eye, and all angles were found to be open. This is the fundus picture which showed that he had advanced glaucomatous optic neuropathy in both the eyes, and in the macula we can see some elevation. Probably there was an SRF. So a probable diagnosis of juvenile open angle glaucoma was made, and he was advised investigations for glaucoma and referred to the vitreoretina clinic. So his corneal thickness came out to be average, 539 and 540 microns. And this is the perimetry of the right eye, which shows advanced field loss. And this is the left eye, which also showed advanced field loss, and left eye was worse than the right eye. In the VR clinic, they examined and made a probable diagnosis of juvenile retinoschisis along with juvenile open angle glaucoma. And these investigations were done. OCT macula on the left side of the screen, where you see subretinal fluid accumulation and elongation of the photoreceptor segments, and there is some cystic changes seen in the inner retinal layer. And the ERG, it showed no negative electronegative B wave, which is typical of retinoschisis. FFA was done to rule out any CSR component, and we do not see any active leakage. There is some amount of pulling of the dye, which could be because of the SRF. So with these findings, the diagnosis of retinoschisis could not be substantiated, and the VR clinic reviewed the patient back to the glaucoma clinic for further management, as they were not planning for any intervention. So in the glaucoma clinic, we increased the medication by additional medications like brimonidine tartrate, netarsudil was added, and patient was explained that if the IOP remained uncontrolled, he might have to undergo filtration surgery. And since we could not come to a definitive conclusion regarding the presence of the fluid, we added we advised him for genetic testing, and blood sample was sent for the same. He was also advised to review back at 6 weeks. So at this point of time, what we had thought that probably the cystic changes and the fluid accumulation is because of the high intraocular pressure and advanced glaucoma. Actually, I was also not aware of such a condition that can happen until this case came to me. So this patient was lost to follow-up. He did not come, and when he came after a year later, we found that he had discontinued all the medications, and he had a left eye surgery elsewhere where trabeculectomy was done, and followed by vitrectomy and silicone oil, and then a cataract surgery with SOR. So on examination, his vision was still maintained at CF 3 meters, pressure of 44, and in the left eye, there was no PL and IOP was 42. So he was advised trabeculectomy in the right eye this time, and post-operatively, these are pictures of his post-op day 2, where we see that the AC is shallow and the IOP was 10 mm AG. After a month, the IOP was always around 10/8, and the vision was counting fingers at 1 meters, but the AC was shallow. This is the OCT which was done at 1 month, and we see that this SRF has reduced to some extent. At 2 months again, we see that the bleb looked overfiltering and the AC was still shallow, very shallow in fact, and there was posterior synechiae. IOP was 11 mmHg, and however, there was no choroidal effusion. And we decided to observe him without any intervention. A UBM was done and it did not show any typical changes except that the anterior chamber was shallow and PAS was noted.
1 second, Shahinur. I think MPB ma'am wants to comment on one of the pictures. So I request MPB ma'am to please share her thoughts.
Yeah, nice case. Actually, the OCT finding is very typical of autosomal recessive bestrophinopathy, which is well known to be associated with glaucoma. I suspect you would have got a BEST mutation in your genetic analysis.
Yes, ma'am. Actually, the genetic testing report came to be bestrophinopathy.
Actually, I want to interrupt, ma'am. Actually, as a VR person, I have seen this case as a last person. So I told them it is looking not like a juvenile retinoschisis to me, and it was looking like a more of a base disease. But after that, we have advised the genetic testing, so we have got confirmed actually, ma'am. So it will be there in the presentation.
Because shitic spaces in the intraretinal space with the derivation of the elongated photos, typical Varov's membrane, this is well associated with a thick choroid, angle closure, and hyperopia. We have quite a few patients with BEST mutation who have glaucoma.
Yes,
okay. But this patient had open angles, ma'am.
So yeah, I think the most cases which have been reported are of angle closure and maybe a shorter axilla, not very short, about 20-21 in literature. But this one was open angle, but yeah, angle dysgenesis has been reported along with BEST retinopathy.
Mona, what were the OCT typical findings Madam describing? Do we have those here? OCT emissions? And go back to that we could diagnose it on the OCT itself, some typical things.
Yes, ma'am. This photoreceptors, if you see, the SRF is there in both the eyes, and even phenopathies like the phenotypic presentation. And you can see the macular schisis there. A lot of pockets. The photoreceptors are very elongated. These just above the SRF part. If you can zoom, ma'am, then you will see.
Thank you.
So subsequently, the patient was kept on regular follow-up at an interval of every 3 months or so, and his endothelial cell count was also low, 1434. So we decided to observe him, and then this is the result of the genetic testing, which came out to be bestrophinopathy only. So about a year later, we found that his vision dropped to counting fingers close to face. However, the IOP was still 10. There was no choroidal effusion. And I discussed with some of my seniors. And then at this point of time, we decided, we were given the option of either trying for a iridozonulohyaloidotomy or for a lensectomy vitrectomy. And it was decided to go ahead with the lensectomy and vitrectomy. So these are the UBM and B-scan pictures of the cases before he was taken up for surgery. So after the surgery, the patient has been on follow-up for a year now. He is maintaining a vision of counting fingers at 50 centimeters, and he is now on dorzolamide timolol fixed dose combination. IOP is 16. And this is the OCT macula picture, which was last done in July this year, which shows some macular edema and schitic changes still present. So what I thought maybe would be worth discussing from the glaucoma point is, how often do we see cases of macular or peripapillary edema in glaucoma patients? Was this a malignant glaucoma? Because the IOP was never high. And what could we have done differently for a better outcome?
I think I'll request Dr. MB sir to comment on the glaucoma part, starting with MB sir.
Yeah. So the first question, I will come to the second and third question, if you can actually put the questions up on screen. Okay, I'm using my mobile. So is it malignant glaucoma? I'm not sure if this is the subtype of the BEST which is described to have aqueous misdirection recently in the series from LVPI. So if you are, you may want to check that part specifically. And it could be a malignant glaucoma also. Possibility is there because the shallow AC started even before the overfiltering started.
Yes,
so, having said that, the third question coming to, in that series, they found that doing a zonal hyalorotomy in the beginning itself with the phaco procedure or the phaco trap helps in these patients. So I think that's something which we may need to explore it, and probably a high awareness on the macular pathology in these patients before surgery itself would help to really do the genetic testing and go ahead with it, I think, unless it is an emergency otherwise. And the first question, this macular or peripapillary edema that we are seeing in glaucoma patients, I don't think it is that common. I mean, not related to any of the vascular problems, that is. But this dystrophy thing itself is a relatively rarer condition, the macular dystrophy with the angle closure type that is existing. I have not seen that many actually. So, I mean, I've seen CSR with the glaucoma pattern, but more in open angle glaucomas, but not with angle closure glaucomas. Yeah.
I think Adi sir has also joined. So, sir, would you like to make a comment about?
Yeah, actually, these macular dystrophies, I have seen a few. They're typically young women, and they typically, I've seen with foveal Shahinur, and I've also seen with a variant of BESS, and they typically behave like this. They'll end up with a shallow anterior chamber, difficult to manage. They'll end up with aqueous misdirection. So very often, if it's a second eye of these patients, I'll end up having to do a prophylactic zonal hyalorotomy and taking out the cataract at the same time. So it's, where is this patient from?
He's from Manipur, sir.
From Manipur, okay, because I have seen a few patients who are actually from Uttarakhand. I've seen at least 3 patients from that area. So, yeah. So there is.
His brother also has he doesn't have glaucoma, but he does have some retinal Shubham. I think the elder brother of this patient also had some retinal findings.
Actually, ma'am, I have seen this case later, but yes, his brother is also having the same bestrophinopathy-like picture in both the eyes. So he don't have a glaucoma. But this child is associated with a juvenile advanced open-angle glaucoma. So before that, it was diagnosed before as a Retinoschisis juvenile. But when I've revisited the case, I've seen all this picture. It was looking different to me. But his brother was not having that advanced glaucoma, but the same picture is there in brother as a SRF and elongated photoreceptors, just like the best variant of bestrophinopathy phenotypic changes that we are seeing. So, but I have gone through the literature. In the absence of beige disease also, there have been various in advanced juvenile glaucoma or advanced cupping, they are having this macular schisis or perifoveal schisis they are mentioning, just like in optic speech what you're seeing. And
there are reports I've read.
Yeah, so that was mentioning that whether advanced cupping could lead to this foveal schisis changes or sometime with the SRF also, just like we see in optic speech. So, but in this case, that was more looking like a elongated photoreceptors and all these things, and I have confirmed with the genetic testing that is a bestrophinopathy. So that part I was not linking initially with that advanced cupping. But yes, in absence of beige disease also, bestrophinopathy, these findings are reported in multiple papers. Recently in IGO also. So peripapillary foveal schisis in advanced cupping.
Can I add something?
Yes, sure, Shweta.
As far as the case reports are concerned, there is one case report in literature which says that a young person around 18 years presented with this kind of peripapillary with advanced glaucoma. And the reasoning they had given was that there were small IOP fluctuations which led to some kind of vitreous traction in the inner retina, which gradually and eventually led to those shiatic cavity developments. And then later, when I did further literature search, it said that there is some kind of interconnection of the fluid from the subarachnoid and the subretinal space, which leads to this kind of shiatic cavity which develops, and eventually as the disease progresses, these fluid they gets on accumulating. And then they had given I can say a suggestion also that later some kind of inflammation, like in your case here, the case which is being managed so well, they said that if through the DSTPC, like if we go for the cyclophotocoagulation, that causes the vitreous liquefaction. And that vitreous liquefaction makes it like kind of a little more permeable for the aqueous. So the occurrence of, because in those particular cases, the occurrence of malignant glaucoma does occurs. So they say that by inducing the inflammation, it promotes a flow of aqueous from the vitreous cavity. So that henceforth, the control of the malignant glaucoma also can be taken care of.
So,
sorry, Mona, one more point. Basically, I remember just now that a couple of patients with smaller axial length, almost like less than 20, and had this iridoschissis as well as retinoschisis, and young patients, and they did not have glaucoma, but they had some borderline intraocular pressures and ended up with, after just a phaco IOL, they ended up with aqueous misdirection. So they are having angle closure to begin with, and formicrust nanophthalmus, retinoschisis. They are not the best kind of patients, and these are young patients. So they ended up, other eye required, both eyes ultimately required parsplanavetectomy with a zonal hylerotomy to ward off aqueous misdirection subsequently. So those are probably two different kinds of patients, but having this kind of schisis and aqueous misdirection issues.
So is
Shahinur, can you stop sharing the screen? Then the recording becomes easier. Sarvanan just called me and told me to, can you stop sharing this?
Yes.
Thank you.
Yeah.
So is the vitreous abnormal in these eyes that predisposes them to aqueous misdirection once the IOP fluctuation or the anterior chamber depth fluctuation occurs? Is it a pathogenic with vitreous, which is more because of the stiff vitreous, the fluid collects behind it? I mean, there are some reports which say that. So that's why the liquefaction releases the traction, and then the schisis also sometimes is known to resolve. Plus, you had also given dorzolamide, right? So is that for the schisis or for the IOP?
No, just for the IOP, not particularly for the schisis, yeah.
Because I think some reports where they say it.
Yes.
Dorzox does matters a lot in these cases. Ma'am, actually, I had read at one place that it said that these particular gene mutation, which is basically responsible for these shiatic cavities, it is also responsible for the fluid balance by binding to sodium potassium ATPase. So when this is disturbed, this kind of shiatic fluid cavity accumulation, it does take place, which is responding well to dorzolamide, as you said. Though I don't know the pathogenesis, that how dorzolamide is going to help in that, but that is there in that literature.
So if I may interrupt, actually speaking, what happens is these are kind of edemas. These are schisis in which you don't have if we do an angiogram, these things don't leak. So they belong to the category of non-leaking CMEs, if you see. And in these non-leaking CMEs, if you are going to give, because see, basically the disturbance for these people are more in the outer side. So we always classify it as inner retinal barrier breach, outer retinal barrier breach. So if you are on the inner retinal barrier breach, then we always tend to say that intravitreal works better. If you are on the outer retinal side, then the dorzolamide works better. So that is how it goes. So in all these category, like if you say retinitis pigmentosa, they tend to be associated with these non-leaking CMEs and with these little bit of schisis which you see. Like for instance, retinoschisis also, there are a lot of reports, and why we have also tried giving this carbonic anhydrase inhibitors. So I mean, it is not like we would say, yeah, it works in every individual. It is kind of case based. In some it might work, in some it doesn't work also. So that also happens. So we don't know which set would respond, which set would not respond. So like for instance, we have tried in retinitis pigmentosa in certain patients. And of course, in Goldman Flavy also, we have tried in certain group of patients. So in some, it does give response, especially the younger individual, not in people who are older. So young individuals, they tend to respond better. Like, and these kind of best patients also, what happens is there is yet another group of patients in whom, if you see, they may not have, they typical features may not be there, but they will also have neovascularization apart from uveitis also. That is another group where the children will have associated features of, so they are called adult. So that is autosomal dominant. They have the similar features, but they will have uveitis which doesn't respond to any modality of treatment associated with the other features. So that is also one group of patients who are associated with the same Western disease, but that is called adverse. So that is another thing which we should remember when you are managing this juvenile glaucoma set of patients, where always you must give them, because they may not be sensitive even to the immune suppression with glucocorticoids. Because they are refractory to that also. All these features plus the uveitis component will also be there in that group of patients.
Ma'am, now for the retinitis pigmentosa, some set of people are also trying Ozurdex, intravitreal Ozurdex for the CME, but I don't know how it is acting, because till now we are only giving carbonic anhydrase inhibitors definitely without a glaucoma component, but yes. I don't know how much it is successful in various reports are there.
Yes, people have tried that also. Say Ozurdex also. As a last resort, sometimes when it doesn't work, but I mean, we cannot say that who works better. But one scale of rule would be that if you have a leaking CME, then it is accepted because it will work. Non-leaking, it doesn't work. But still, yeah, that's a good way to, titrate your thing about where to use and which drug would work better.
Yes, ma'am.
Coming to patients who are having this aqueous misdirection, when we probably have, these people have, we don't know how exactly the choroid is functioning in them. Like MP sir was pointing about a patient who had an axial length of 20 millimeters and then who also required a zonulohyaloidotomy. So these are patients who are like probably behaving like nanophthalmic patients only, wherein you kind of have the evioscleral outflow is mostly affected. So that is one set of group where if you try to do a phacotrap without a zonulohyaloidotomy, then it probably does not work that better. So that is another set of patients wherein we'll have to very carefully see that this aqueous misdirection, if it happens in one eye, you'll have to be careful with the other eye. So one good point in these patients would be, a good measure would be to probably measure the scleral thickness by using UPM. UPM can measure the peripheral scleral thickness or your ASOCT also. So if you can use that to help, then you can probably catch hold of these patients who might, because these borderline patients who are at axial length of 20 like that, hypermetropes, you can probably use that, the scleral thickness to gauge if that can be one way of using it. There are kind of lot of literature evidence on that, like if you measure the scleral thickness and preemptively prepare these patients, so that you can prevent the malignant glaucoma from occurring in these patients.
Yeah, also, I think there's a scleral thickness more than 3 mm is more significant for UPM cases.
Yes, so that is what. So that can be used by using ASOCT or UPM also.
So if you have a thick sclera pre-op in such eyes, borderline axial length, would you do a sclerotomy or would you do an intra-op iridozonal hyalotectomy?
So if it's of a milder form, probably you might get away with the zonular hyalodotomy, though the mechanism is different in that, because you probably are actually relieving the vitreous part of it. So you are relieving the condition from inside. But if you are having a more thicker sclera, then you probably err on the side of doing a sclerectomy, creating a window, like how you treat nanophthalmic eyes, you know. Yeah, so like that you will have to treat. Because this will probably help you in the immediate post-op. Your zonular hyalodotomy might help you in the immediate post-op, but in the long run, how much it would help, because the pathogenesis is going to be different.
So for a more thicker sclera, you are suggesting sclerostomy?
Yes.
Sclerectomy,
You will have to increase the outflow that way.
Okay.
So that means, ma'am, when we are planning for any glaucoma surgery, primary glaucoma surgery, we should go for the sclerostomy first at the same sitting, and then we go ahead and do the glaucoma filtering procedure.
No. See, glaucoma filtering procedure is also, you are kind of, you punch the sclera and then only you take a punch through the uveal tissue, isn't it? So that is also, in a way, it is kind of enhancing the outflow through that route also. Because your sclerectomy, what you're going to be doing is not very far. See, there are people who are doing sclerectomies anterior to the muscle insertion, some of them doing posterior to the muscle insertion. There is no uniform rule as to how many sclerectomies to be done, because most of them prefer doing a 4-quadrant. But we have seen in SN only a 2-quadrant sclerectomies have worked really well, because it is more of gravitational. So inferior, if we do, it's a dependent drainage. So that much is enough. We don't have to do a 4-quadrant. We are doing only 2 quadrants for all these kind of uveal effusion syndromes nowadays.
But in patients with nanophthalmos and glaucoma, we combine the trab with the sclerectomy. Just the trab doesn't take care of the post-op occurrence of CDs, shallow AC, and aqueous.
See, doing a trab alone in such a thick sclera may not help. So those kind of cases definitely, but then as of now, we are following the axial length cutoff values or nanophthalmic kind of eyes only we take into consideration for this sclerectomy. Otherwise, if it's just a pure angle closure eye, which is more prone for aqueous misdirection, it is vitrectomy with zonal hyalotomy is what we combine it. That too, we choose on the basis of the other eye reaction or very high risk of aqueous misdirection. So doing a sclerectomy right now, axial length is the cutoff value. Scleral thickness, there are papers, but I'm not sure whether that alone will suffice for us to really go in for such an invasive procedure. So just doing sclerotomy in the trabeculectomy part of it alone will not take care of it in nanophthalmic kind of cases.
So, if there are any more comments, they're welcome. Otherwise, we can shift to the second case.
So, what's the answer to Shahinur's question? What different you would have done here at this? One of the questions was what else I could have done to give the treatment, to make the treatment better.
For that, ma'am, I just
should we have intervened earlier with the lensectomy, vitrectomy part? Because we have waited for a considerable period of time with a very shallow AC.
I think having the diagnosis of the retinal condition with the genetic thing, now we have some evidence in terms of case series that aqueous misdirection is a possibility in these eyes and probably could have intervened earlier. But as of now, whether to do a prophylactic thing itself in the beginning itself or not is a question of debate and discussion only, because we have only one series in this whole thing. And these are probably high-risk eyes, and individual case-to-case basis only you can decide about the prophylactic vitrectomy with the zonal hyalotomy. But probably an earlier post-operative course of intervention would have helped. Having known this, best subtype is seen in this case.
So what about the role of this limited diode which causes the vitreous liquefaction and causes it to reverse? It's been mentioned in a couple of case reports, but would it really work in such a case?
So Mona, I'm not sure whether it's vitreous liquefaction there or whether it's just breaking the zonal capsular block. Because once you disrupt the ciliary process there, you're relieving the block and the aqueous misdirection potentially gets reduced. So, see, these are rare cases. They come to you, you just have to have a higher index of suspicion, tie them down tight. Or if you're going to do the other eye of this patient, you're definitely going to add on something prophylactic. And all of us have burnt our fingers like this and learnt after that. So it's very difficult when a patient is marginal for you to, because doing a sclerotomy sclerectomy is also an invasive procedure. So the only learning now is that if you notice the shallowing, intervene a little earlier, because they don't usually settle down without surgical intervention.
So that means we no need to give the trial with the diode CPC, which has been mentioned in the literature. Straight away we go for the surgical intervention with the IZHV.
So that's the most definitive treatment for this, right?
So phakic eyes, would you sacrifice the lens then? It's a young patient.
See, I didn't want to bring it up, but one of the things here is that you wonder whether the lens is also a little mobile in these patients. Because the gut feeling is when you're going to these eyes, the lens feels a bit mobile. So taking it off, therefore, makes a little bit more sense. But see, we are all talking about a handful. Between us, we may have seen 15 or 20 patients. There's no evidence to support this. So doing a diode in a patient like this, again, is a bit of a issue. Young patient, cyclodestructive procedure, and you're not sure whether it's going to work.
So I would again stick to doing diode in only very poor vision and not in one-eyed patients kind of thing, because the vitritis that is coming along with the diode, as well as the optic nerve involvement that happens with any amount of diode that is happening there because of the inflammation, is going to drop the vision of the patient and the contrast of the patient quite a bit. So I don't think that is something very ideal. But having said that, one of the patients which I had a platyvirus phaco-IYL aqueous misdirection in one eye, the other eye the vision was like not that much, and when I did the surgery for that eye, so I combined it with the diode CPC, and I did the diode CPC first and then went ahead with the cataract surgery, and that didn't have aqueous misdirection, but then that is not evidence enough to say that diode CPC worked. But as such, aqueous suppression using diode CPC, also doing this, will decrease the amount of posterior misdirection that's going to happen. So that way it makes sense theoretically, but the side effects are not good enough for us to suggest it as a routine.
They do also say so that with the diode CPC, they change the orientation of the ciliary body, which is kind of deepening the AC. So probably that is one of the factors which we can say that prevents further shallowing of AC and further accentuation of the IUP.
I think that's a secondary process that happens because of the decreased aqueous production is what I think, because the amount of aqueous lake in the back decreases and probably pushing the whole lens iris diaphragm back, and that is causing the direction change rather than as a primary thing. So I'm not sure if anyone else has any other thinking in this.
So shall I go to the second case?
Yeah, it'll be nice.
Am I visible?
Yes.
I will present my second case, that is the surgical management of neovascular glaucoma and challenges. We had a 59-year-old gentleman who was referred to our institute for diode laser cyclophotocoagulation in his left eye. He gave a history of consultation elsewhere where he received intravitreal anti-VEGF injection 4 to 5 days back. So he was diabetic and hypertensive, and he was on antibiotic steroid combination, atropine eye drop, and brinzolamide brimonidine fixed combination. On examination, the visual acuity in the right eye was PL present, PR inaccurate. Left eye had counting fingers at 3 meters. The right eye, the cornea was clear, but the left eye had microcystic edema, and the pupil was festooned in the right eye with cataractous lens, and the left eye had a mid-dilated pupil with ectropion UVA, and the lens was cataractous. The IOP was 67 in the left eye, and on gonioscopy, all the angles were closed. And the fundoscopy was done, and because of vitreous hemorrhage, there was no view in the right eye. And the left eye, despite the presence of microcystic edema, we could see that the retina was on, and he had advanced glaucomatous optic neuropathy. So, probable diagnosis of age-related cataract, vitreous hemorrhage in the right eye, and secondary glaucoma, neovascular glaucoma was made for the left eye, and status post intravitreal injection anti-VEGF. He was advised B scan for the right eye and HR OCT for the left eye and referred to the VR clinic. So this is the finding noted by our VR colleague, and there was evidence of old CRVO. This is the B scan picture of the right eye, which shows tractional RD in the right eye with vitreous hemorrhage, and the left eye OCT shows parafoveal macular edema. Edema in the parafoveal area with foveal thinning. So he was advised for PRP 3 sittings from the VR clinic, and from the glaucoma department, actually, after seeing the patient initially who was sent for DLCP, when I saw the patient, he had no neovascularization in the anterior segment. Although the IOP was high, there was no NVI or NVA, and vision was counting fingers at 3 meters. So I thought maybe we would be able to do a glaucoma drainage device. And it was decided that after the PRP, we would proceed for the same. But in view of the corneal edema, which only worsened, the planned PRP could not be done. So it was decided that we will go ahead with cataract surgery combined with glaucoma drainage device. Here I would just like to explain that initially I had planned to do an Ahmed glaucoma valve, because at that point of time I had done only few GDDs, and I think this was my first ADI case. But because of financial constraints, I had to take the case for ADI with FECO. And I really didn't know the implications of doing an ADI in this case, and I thought it would be fine. So post-operatively, the medications that all the anti-glaucoma medications were continued for him with topical steroid, antibiotic, atropine, and oral acetazolamide. On the first post-operative day, his vision was hand movement in the left eye with corneal edema, and the IOP was 50 mmHg. So on 2 subsequent days, when the picture was the same, we had to inject mannitol 200 ml. So by post-op day 13, the IOP was still in the 40s, but cornea had started to clear up and his vision was counting fingers at 2 meters. The patient was then taken up for the PRP, and 2 sittings of PRP was done. So this is an image of the patient where you can see the vicryl suture ligation of the tube, and at 6 exactly, during the entire period, the patient had an IOP above 30, between 30 and 40, although I had made venting slits. And finally, at 6 weeks, the ligature gave way, and the IOP came down to 10 mmHg, and he came with a shallow AC with choroidal effusion. So the patient was put on conservative management for resolution of the choroidal effusion, and he was followed up closely. And in this picture on the left-hand side, what we noticed soon in the next few days, that there was a vertical conjunctival tear along the scleral patch graft. So from the beginning itself, I had noticed that in the scleral patch graft, that edge was quite sharp. And I think that was the reason why ultimately that part of the conjunctiva gave way. So I repaired the conjunctival gap with the help of PRF, and of course sutures were applied. This is the post-operative picture. So 6 months later, this at the final checkup, I'm sorry I missed that slide actually in putting it up in the presentation. At final checkup, that is around 6 weeks, the patient had a good vision of counting fingers at 2 meters, and the IOP was around 12 mm Hg. So the patient was coming at a regular follow-up of around 6 weeks to 2 months, and he was followed up for 6 months. So finally, he started developing NVI again, and the IOP was, however, still around 10, 12, like that. And this is a fibrinous membrane over the IOL. Even in the presence of NVI, we just chose to follow up the patient, but over the next few visits, we saw that a fibrinous membrane had developed over the IOL. So at last, we decided that an intravitreal anti-VEGF injection would be given and followed by a laser membranectomy. However, the patient did not follow up after that, and in fact, for this presentation, when I was just going through the file, we tried contacting the patient, and he is actually a Pandit in a temple. Somebody who had received the phone said, "We'll call you back," but they have not got back to us. So in presenting this case, my question again would be, what best could we have done? Of course, that first point I'll answer myself. I think maybe an Ahmed glaucoma valve would have been a better option in this case. The second point is there any way we could have prevented the appearance of the NVI and the membrane formation now? And third question is, what can we do now? What we planned, is it a good plan or, yeah.
Yes, so maybe I'll start. Shahinur, is this a patient I saw?
Yes, sir. The same patient you saw, I think, after the PRF was, or before it, I can't remember. I had shown you the patient,
Yeah.
sir.
Yeah. So I agree. I mean, an AGV would definitely have been a better option. And see, regarding whether you can prevent the NVI and the membrane formation, it's basically because as inadequate, there is still significant VEGF being secreted. So the retinal ablation is probably inadequate. That's the only other reason, because the eye otherwise looks quiet. The second possibility can be inflammatory, but the patient has been coming regularly and he's just developed this sort of neovascularization again. That's about it. It's not so much a glaucoma surgeon's purview as a retina surgeon's.
I think this is kind of the story in many of our NVG patients. But I'm wondering, preoperatively, you couldn't give any intravitreal anti-VEGF before taking up for surgery, is it? PRP is done, yes, I agree. But, suppressing the VEGF as much as possible by a preoperative
The patient had already received anti-VEGF from NSWEP.
Okay, then that should be fine. And of course, as Ronnie said, an aggressive PRP at the first opportunity post-operatively. Again, whatever fill-in PRP, these kind of eyes really require an aggressive PRP. So that would have prevented the subsequent complication. But having said that, we don't know what kind of a diabetic control this patient had. So that is another issue. That is something which we need to keep following up in these patients, that we often forget. Actually, a diabetologist to monitor regularly would be a better option as well. Those are the two things I can think about.
So Shahinur, when was the anti-VEGF given for this patient?
He came to 4 to 5 days maybe prior to his visit to our institute. So he went to the medical college where he received the anti-VEGF, and then he went to our private practitioner who had referred to me, because I think when he visited the private practitioner, it was still, NVI was still there, and he He must have thought that it's a hopeless case and sent for DLCP. So by the time he came to me, the neovascularization was gone and the vision was counting fingers 3 meters. So I thought maybe we could do something to salvage the only seeing eye.
Yeah. So actually speaking, because your OCT on the first time, it was showing a sectoral edema. So these kind of edemas are more predominantly seen in a branch vein occlusion rather than a central retinal vein occlusion. Because your OCT.
Yeah, Shubham, you have seen this case.
Hello. Yeah, yes, ma'am. Actually, if you see the optos picture, then there's a lot of diffuse hemorrhages, ma'am. It is not particularly in a IT BRV or ST BRV like cases. Apart from that, there was some rod spots. So I was just trying to rule out any anemia or any related peripheral smear to why the rod spots will be there in the CRVO picture. But there was a hemorrhage was diffuse. There was not any particular segment. And yes, there could be component because in the diagram I showed there was sclerosed vessels going above and the superior arcade was inferior arcade also. But the hemorrhages were diffuse. It was not localized to any particular quadrant to.
See, that highlights one more important.
Maybe because he had received anti-VEGF.
No, see, there could be one more element. Probably there is a component of arterial occlusion as well. Because, or if you have an ischemia, because of course we don't have an angiogram to show the extent of ischemia. Or was there, because this is a patient who had he went in to have an occlusion and then a glaucoma. Or was it a glaucoma leading on into occlusion? So which was the one which came first? Because that is very important information in this particular patient. So was it a pre-existing glaucoma which ended up having an occlusion? Or was it an other way around, occlusion? Because usually glaucoma patients going in for an occlusion, they will have very silent components. They don't present like the proper florid picture, they'll be so silent. So it's always mandatory, like for instance, if we get a glaucoma patient, we always err on the side of going in for an angiogram to see how much is the extent of capillary non-perfusion, so that even the wide field angiogram we ask for, so that the laser to the non-perfusion should start off at the earliest thing, the moment you diagnose that, because they are very silent occlusions which happen. Rather than the CRVO leading on into glaucoma, they are very florid. So in this patient, which came first?
Because when I received the patient in my department, both the component was IOP was 67. It was a picture inside was a CRVO picture. So which is the first to occur is difficult to say, and the other also.
The history which he gave, he was diabetic for the last 3-4 years and hypertensive since 1 month. So it was undiagnosed disease, or
But there was no NVE in the retina. In the retina, there was no neovascularization apart from this CRVO-like picture and high IOP. But yes, there is a global ischemia. And if you see the OCT, ma'am, it is a very chronic CME. It's not that a very fresh onset CME. So he has received intravitreal elsewhere, but it was not a very fresh looking because all the sciatic spaces were turbid.
So one eye is having already a vitreous hemorrhage. Again, that has no
vitreous hemorrhage and a total gross TRD.
That was treatment naive eye also.
Yes, ma'am.
Yeah. So treatment naive eye one side and the other eye having. So in that case we take it as probably occlusion and then going on into having a neovascularization.
Glaucoma.
So in that case, probably there is a component of arterial element also. That explains your OCT having sectoral edema in one quadrant and the other quadrant going in for a thinning. So there is probably an arterial element. So it can be a mixed occlusion as well.
Combined occlusion.
Yes. So that will explain the way how things have gone on. So in these kind of situations, what we must do is, because anti-VEGF is already given, the moment the surgery is being done, the post-operative period, we have to be really ruthless in doing the laser, which means very aggressive. Start from the posterior pole and end it until the aura. Even in spite of that, we can still have problems in these patients. In spite of doing all these things, many a times what we realize is the neovascularization would not come down. And in the other hand, sometimes if you have operated these patients for a vitrectomy, you may have to keep the oil inside the eye just because so that, sometimes silicone oil becomes a mechanical tamponade. Otherwise, these patients keep on bleeding again and again if you do a vitrectomy in these patients. See, if the patient had a vitreous hemorrhage and you combine it with a phaco trap and then do vitrectomy, many a times we tend to realize they keep bleeding again and again, even in spite of a well-ablated retina, and we do an anterior cryo also. So these are patients, sometimes, oil will help, and removal of oil may not be possible, because if you remove oil, then it will again start bleeding. I'm sure Rajiv sir will know better about this, because these kind of NVGs, we rather tend to keep the oil in that eye.
Yeah, ma'am. Also, we tried lasering the patient, but I have blasted with a laser that time. But yes, the indentation I could not do to have that because of a phase post-op patient with the Adi plant. So we cannot do that indentation to go to that much aura. But whatever we can ablate up to that visible extent, we have ablated in 2 sittings. Because had it been done in the pre-op, maybe I have indented much more and gone one anteriorly. So that was one limitation for us to have indentation and do up to aura. That could have been done in the pre-op period rather than the post-op period. So yes, that is one thing. But yes, the patient tend to recur that neovascularization because in between he is coming. And anti-VEGF, I was just depend, but foveal component was almost like same. It never was a very cross edema in between and then again it coming down. So it was more like a ischemic retina in the ischemic for macula, more or less in the posterior pole. But after that, the patient again lost to follow-up. So we never know what happened.
So, ma'am, what is the role for ARC in these cases then?
Yeah, so if the patient's visual potential is not too much, then we err on the side of having ARC. See, ARC is always good to do because it helps you. You can do ARC combined with a limited diode and then follow the patient up. We have done the other way around also in many patients. We've done ARC diode and then followed it up with phaco trap. That has also worked well. So when you're doing a cryo, one good thing would be to not to ablate the superior, not to do cryotherapy to the superior quadrants, because anyway the area where the trap is coming, you don't want any kind of fibrosis to occur. So cryotherapy, if you can leave spare at least the 4 clock hours superiorly and do the cryo rest of the area, we have many a time seen that 1 month after the cryotherapy itself, it starts clearing up better. Then we are able to do the laser also. In fact, we are able to do the laser, and this diode also has taken care of it. And after that, we have got some set of patients in whom we have done ARC, diode, and then a month later we have done some laser, and then within 3 months a phaco trap has been done and a patient is holding on vision of 6/18 also. So that one-eyed patient. So we have done the other way around also. So it is mandatory that you have to decide depending upon how good is your visibility. That is what I would say. If you have a cataract lens, then you have no other choice but to remove. So do anti-VEGF and then remove the cataract and then do the trap. Then after that, post-operative laser. So that is one way of taking this. Or if your visibility is very, the moment it is only because of a high IOP, the corneal edema is the only culprit which is there, means in that situation, then you can even probably err on the side of doing an ARC also. That also helps. But that superior 4 clock hours alone, we need to not to do the cryo over there, because then trap will fail if we do cryo in that area. Spare that and do in the cryo in the other areas.
But ma'am, do you recommend doing cryo in the post-op period, because it was already inflamed eye, and even if you can't complete that anterior, so doing a cryo in the post-op period more inside the inflammation actually more. So
no, actually, see, in the post-operative period, if you are able to cross your incubator and go,
that to have done.
Well, that is most important. See, these eyes require round about 7,000 burns at least.
Yes.
7,000 yearly.
ARC, the chemosis is a lot. It takes more than a month to go. So I don't know, the valve in there already with the amount of chemosis is really amazing. I've been following up a couple of patients. It takes at least 6 weeks for the chemosis to go. And while we monitor the IOP, I've had one patient whose pressure was 20 NDA with open angles before the only ARC, because since IOP was okay, we didn't do any procedure for the pressure. Post ARC, the IOP went up to 50 because of the shear chemosis, and it took a while for that pressure to settle down. So I think the increase in the episcleral pressure secondary to that maybe was the cause. Or the outflow, but it took a while for the pressure to come back to what it was pre-ARC. So that is one challenge which we see with ARC patients.
But laser is actually good enough. If you are not able to do it on one day, you face it up. You can call the patient 2 times, not only 2 times, 3 times, 4 times also we have done like that. So rather than doing it in 3 sittings, take it 4 sittings or like that also, because patient also cannot tolerate pain, that much laser to do. So, but we have done that in the post-operative period itself. From day 3 onwards, we have started lasering.
Laser, yes.
Yes. So that is actually help. That definitely helps.
Yeah, that's what we have done, man. Because the moment you get a window of little clear cornea, we just blasted it to the possible into just 2 sittings, completely covering the entire way, rather than waiting for 3 sittings. Because even the posterior period, the IOP was 50s, in 50s or 50 or 40, late 40s. So it took a little, at most 10-12 days for the cornea to get little better, so that you can at least complete the PRP.
So I just have one question, Dr. Shahinur, when you said that the patient had the reappearance of NVI with the inflammatory membrane, so because sir said that definitely that angiogenesis is taking place, that's why the NVI is again coming up. So what was the fundus status at that point of time? Was the disease, like the retinal disease was progressing, or what was the reason?
The NVI and the initially we saw few twigs of neovascularization on the iris, and then we were wondering what to do, because the retina also, I think, Shubham, there was no worsening of the
fresh
retina.
bleeding we could see actually.
Yeah, it was stable. Only the presence of NVI was there, and the eye was quiet. So over the next few weeks, in the next few visits, slowly this membrane started appearing. So once the membrane appeared, then we thought that it's time to do something. And his vision, I think it dropped to, again, counting fingers, 50 centimeters in the last visit.
So I think the last question is still unanswered, what to do next for the patient.
Yes.
Shahinur, did you rule out vasculitis, Takayasu or carotid Doppler? You know, ocular ischemia, all those things have been ruled out because the cause, we are here thinking of CRVO or combined occlusion. You know, there is probably, we need to look a little deeper beyond.
No, ma'am, it was not advised, Shubham. I think
because the initial picture and everything, it was not looking like a vasculitis because we didn't get any inflammatory component like any sheath.
No, so you see, that's exactly what I was also thinking about.
It was just a very routine. So we didn't get any signs of inflammation to think in that way. And moreover, in the event of a patient, have a diabetic patient, otherwise already in the gross TRD, which may be because patient was not followed in time. So the eye was lost because of severe gross TRD and vitreous hemorrhage. But other eye, that's madam was saying, whether the glaucoma was before or the CRVO was before causing the glaucoma. So that was one thing, but it was not looking like a very like inflammatory eyes that we see a lot of vitritis or at least sheathing in all the quadrants or something that will strike us to look for any inflammatory component. Even after the PRP, the patient remains stable for almost 6 months without any immunosuppressants or something like that. But when he came up with later with some inflammation with a fibrinous membrane and an NVI component, but even in the posterior segment, we didn't see any gross NVs or some bleeding or something vitreous hemorrhage that happened. But before advising something or doing something, because the patient again lost to follow up, so we turned up so that we can plan something and do something with the patient.
I think Ronnie was saying something.
Yeah, so other than vasculitis, I think one thing you need to look for is whether there's hypoperfusion because of any reason. So sometimes these patients are being very aggressively treated for hypertension because this patient was recently detected to be hypertensive. So if they're on 9 doses of blood pressure medicines and they're dropping at night, you can get hypoperfusion, which can again give rise to ischemia-like changes. And the decrease in blood in vision is again suggestive of this, because if you're going to get significant optic disc hypoperfusion, it can lead to a sort of ischemic neuropathy type of picture. I mean, I agree that inflammation you probably would have picked up earlier because you had PRP, you've seen it multiple times. But systemically, this is always a concern. And I have a feeling that this patient was not very compliant in general, both systemically and otherwise. So you need to really explore whether he's getting his systemic parameters also monitored adequately.
One point to add would be as Arti sir said, systemic parameters, yes, we don't know whether he's got renal issues or not and all those things. But apart from that, these kind of eyes in with neovascular glaucoma was there. I usually perform angiogram even after a laser is being done, because you may tend to see, in spite of an well-ablated retina, you can have non-perfusion areas. So, and then you probably need to treat that as well. So that is one thing. If you do, then from our side, whatever maximum effort we can do when the patient is well controlled. See, this is a time, the angiogram has to be done in a time when the patient is adequately controlled on his intraocular pressure and a good view of the fundus is possible. So at that time, if you do, see, we tend to think we have done good laser. That's what we all assume. But when you see the angiogram, you will realize there will be so much areas which needs the laser and wherein the laser was not performed, and that becomes the nidus for them to throw up neovascularization. So in fact, yet another thing is also now become most important is post-vitrectomy. We all tend to think after vitrectomy, we have removed the vitreous, now cleared up the neovascularization, nothing is going to happen. But later on, we always encounter patients having repeated trickle of hemorrhages and all these things. So when we see that repeated hemorrhages, I used to think, why is this patient, we have ablated well. So of late, I've started doing angiogram on this vitrectomy side, because once you remove the vitreous, it's not going to grow into the vitreous, it will grow only anteriorly. So if we don't, and we tend to think it is a sclerotomy side polyps. But what actually happens is the ablation, which we have done inside, that ablation might fall short. So when you do an angiogram, you will tend to know that there are a lot more existing areas of non-perfusion because of these poorly controlled diabetics. If you take care of that, it in fact helps in terms of preventing recurrent vitreous hemorrhages also in a vitrectomized eye.
So coming back to the glaucoma part, so any tips for a non-valve device in these kind of situations? Any other tips?
The use of ripcord, ma'am, because now because of this supramed and ripcord thing coming up, these are doing pretty well in NVGIs. So that is the new addition onto that. That is the only thing. And when we put that ripcord, 2 ligation sutures, which is ideally recommended, is like one is towards that ripcord area and one is just adjacent to that area. So that way it will not give way immediately and the pressures will not come down. So the chances of hypertony is going to be to a much lesser extent as compared to without the supramid and the 2 ligation sutures.
No, here my problem was with the IOP not getting controlled in the post-operative period, and throughout that entire post-operative period, I was really scared that the vision might just go, But fortunately, he withstood everything, and at the final checkup, he did have a good vision. So my learning experience from this case was, if the IOP is higher than 30 with maximum medication, I think AGV is a better option. Would RG sir like to comment on that? Because this is what I have felt in the cases that I have done.
Yeah, I think I agree with you, because generally speaking, if the intraocular pressures are very high on maximum medical therapy that you can give the patient, doing a valve implant is much safer. And I was recently discussing a situation like this with a colleague who wanted lower IOPs in the post-op period, a colleague not in our hospital, somewhere else, and he went ahead and did a ADI with a ripcord. And finally, in a few days' time or 10 days' time, the patient is throwing up because pressures are 60 and 70. So it's sometimes very difficult to manage these patients, and you have to take off the ripcord, and if you're going to take it off that early, you can end up with all the issues that you have of an IOP dropping from 60 to 8 without a capsule having been formed. And you can sometimes go round and round in circles with that. But having said that, if you have no other options, then a ripcord and an ADI is the way to go instead of an ADI alone. But generally speaking, it's not something that I would do
So
as
first has been described with these non-valve devices, the bowelt and often trab. What do you think about?
And
kind of just to tide over that period, you think it'll work or add to the hypotony?
There are people who have done a trab along with both an AGV also to tide over the hypertensive phase. The problem is, see, with an AGV, it's still okay because you have a valve there. It's not going to open below that pressure. But with an ADI, if anybody can predict what your trap is going to behave like, I mean, you please let me know, because I don't know what my traps are going to behave like. The ones which I think will fail will sometimes land up with IOPs of 4 and 5, and after that the ADI also opens up. And you're in real trouble.
Yeah, I agree completely. It's like having two time bombs in the eye, trap as well as the ADI. So I think AGV is a better way to go in these kind of eyes, especially when two departments are involved, because the post-operative course seems to be much smoother with the valved implants, even though the lower IOPs, that's the only advantage with the non-valved implants. So I think that, and the hypertensive phase. So in the post-operative period, if you want to deal with other departments, I think I prefer valved implants.
Sir, and sir, what would be the take? Like we have studied, and the literature search is also coming up. It's been done also in Moorfields and all, that they are injecting mitomycin over the plate, sir. So how do we go about it, sir? Because if the hypertensive phase is there, and we do feel that the fibrosis has started taking place, so how do we inject the mitomycin? What they were suggesting was, even I heard at PGI also, sir, that Sushmita ma'am is doing, she's injecting with a tuberculin syringe.
I'm doing it.
So how do you do that? So how do you do that?
Yeah, I'm injecting it over the plate at week 1 and 4 weeks. 2 injections over the plate, 0.1 ml in double dilution. I mean 0.02 mg.
Yeah, that's the recommended one. Even as early as 3rd day, they are doing it. But well away from the valve area if you are using a valve implant.
Yeah.
So that is the only thing.
All the valves are doing, I mean, all the GDDs are doing good. I mean, in all the cases that I have injected. After doing 2-3 cases, I started this injection, and they're all doing good.
So that hypertensive phase can be reduced with that. Like, what is your follow-up studies, the period saying, Shahinur? Like, what's your observation over that?
Yeah, my cases, I'm not getting these tense blebs anymore. Even though many of the AGVs, I have to put them on anti-glaucoma medications eventually, but the bleb over the plates are like more diffuse.
So, Shahinur, are you using aqueous suppression routinely in your AGVs?
Pardon, sir?
Are you using aqueous suppressants routinely in your AGVs?
No, sir, I'm not using it now.
So, because what we found when we looked at our data is that our hypertensive phase dropped from.
For AGV, yes, sir. For AGVs, depending on the IOP, sir. Whenever I see the IOP going up, then only I'm adding.
So what we are doing is, for us, I mean, for me, I start them on day 1 itself.
Okay.
But some people like to start once moment IOP crosses 10. So we start on an aqueous suppressant from that time, which is maybe timolol or dorzolamide or whatever it is. And with that, when we looked at our historical data versus this, we found that our ocular hypertensive phase dropped from 40-45% to 12%.
Yes, sir. Sir, that's what, sir, I should say thank you to you for the same, sir, because I discussed it with you. I heard you talking about this, and now I started using, the minute it is like 14, 15, no, mid-teens. I put the patient on aqueous suppressants, and by God's grace, the hypertensive phase doesn't come that way, the way it used to come. So that is.
Shweta, I think the recommendation is beyond 10 millimeters of mercury or within first week. So if the IOP is not even going up beyond 10, within the first week, you can, at the end of first week, you can start it off, even if it is lower, because by the time the tubal, peritubal leak and all will be less. So then you can actually, confidently put on aqueous suppressants. Only thing is sometimes if it is less than 10, I only start on timolol, not on a combination. Usually I start a fixed drug combination like a dorzolamide timolol combination, because in the long run I find it, my hypertensive phase almost so far maybe 1 or 2 cases only I had with the aqueous suppression starting. So I never needed this mitomycin C except in very refractory cases like post-vitreous surgery cases, or in case of very refractory cases. So otherwise mitomycin C is not used when you have this aqueous suppression done.
So I think any final concluding comments, because it's been a really, really long day actually for many of us. So any final comments?
I would like one suggestion. The plan that we have made for this patient, intravitreal anti-VEGF again, followed by YAG laser membranectomy for him. Is it all right, or we should consider something else?
No, I think it's fine. Consider adding a anti-retinal cryo if you think there is active, because your intravitreal will only take care of it. It's only a temporary phenomenon, right? You still haven't addressed the primary cause of the neovascularization. So you will need to do something for that. You will need to reduce the VEGF load going forward. So I would actually consider an ARC if that's at all possible. And definitely go ahead with the YAG after the anti-VEGF. But maybe start the patient, treat the patient with topical steroids for a week or 2 before you do it. Because this is a vascular membrane and it might bleed. So the inflammation will help, and the anti-VEGF will both help to reduce that risk.
So I think thank you, Shahinur, for sharing your challenges with us. And it makes us wiser. So the first case was a very interesting, I'll summarize now, I think. So the first case was a very interesting and challenging cases, and I think you should please publish it. It's a rare case, and we should look for in young people with angle closure, aqueous misdirection. We should definitely look out for the associated retinal causes or any other predisposing factors, and we should not hesitate to go in and be more proactive rather than wait, as we discussed earlier. And a good axial length, measuring the scleral thickness, and going in for iridose or zonulohyalidectomy, or if required sclerectomy, depending on whichever is applicable for that case. It's a case-based scenario, but definitely we need to be, before going in for surgery also, I feel we should be more proactive and investigate the case to see what we are heading for. And the second case, of course, NBG is always aggressive and challenging, and it needs cooperation from our retina colleagues so that they find the avascular retina and burn it, like Dr. Suganeswari said, even this after a PRP, and preferably an AGV in these eyes as opposed to a non-valve device, with starting aqueous suppressants in the early phase, once maybe the first day, or other than that, if once the IOP starts crossing 10. And Dr. Shahinur has had good experience with mitomycin C also to avoid the hypertensive phase. And always keep looking for the systemic control and look out for any other cause of the decreased perfusion, unusual causes like an evening dose of antihypertensive, like Sir mentioned, or a carotid Doppler maybe, to monitor the progressive disease, because these people have many pathologies together. It may not be just one disease going on together. So thank you so much, everyone, for being here so late. Any comments? SRV Ma'am, Maji Sir, Henry Sir, Shweta.
Congratulations. Thank you everyone, especially Dr. Rajiv.
Well done. Thank you.
Thank you.
Thank you.
Thank you, everyone. Thank you.
Once
Thank you,
again,
good
and
night.
for the opportunity too. Yeah.
Yes.
Good night.
Thank you very much for the opportunity, ma'am. Thank you. Thank you, sir.
Always
Good
good to
night,
see you
sir.
guys.
Good night.
Wait, we'll take a picture.
Oh,
Yeah, cameras on, please.
Oscar, put your camera on.
I don't know. I don't know.
Suganeswari.
I'm taking a picture.
Oh, you're taking? Okay.
Thank you. Good night.
Good night.
Thank you.
Thank you.
Good night.
I think next month we'll have the Konya powwow, so please keep tuned.
Yes, next one is the corner. I thought it was oculoplasty.
Sorry, my bad.
Bye-bye.
Yeah, oculoplasty then Konya.
Yeah. So good discussions.
Ma'am also joined from the train.
Yeah, that's so nice, no? To actually. Okay. Good night.